Good morning, everybody. Good morning. Welcome to the latest AWMSG Open Day. Today we're talking medicines optimization. For those of you who don't know me, my name is Stephen Lister, health economist at Bristol Myers Squibb. I've been associated with AWMSG for the best part of 15 years. It's been a moving feast during that time. But today, medicines optimization, really past, present, future. National prescribing indicators led by the team at the All Welsh Analytical Prescribing Support Units. That's WAPSU, and that's Kath Haynes, Tom Curran, Claire Thomas, and Richard Boldero. Well, without further ado, let me pass you over to Kath, who's going to kick us off. Oh, by the way, if you have any questions throughout, please pop your hand up, and then we'll unmute you, and you can jump in with a question. Alternatively, we'll take questions at the end. Anything you want to pop in the chat, feel free. All right, so Kath, over to you. Thank you.
Thank you, Steve. Can you hear me enough? Is that okay? Okay, thank you. Good morning, everyone. Thank you for coming. My name is Kath Haynes, head of the Welsh Analytical Prescribing Support Unit within the All Wales Therapeutics and Toxicology Centre, which is the secretariat to the All Wales Medicines Strategy Group, AWMSG. Lots of acronyms here. I lead on data and medicines optimization for the organisation. I will be handing over to Tom, Claire and Richard after my few slides. Next slide, please. So AWMSG Remit is broadly categorised by health technology appraisal and medicines optimization consideration, as you are probably aware. We will be concentrating on the meds op resource development side today, although some of our work within AWTTC obviously overlaps in many different ways, of course. Next, please. Sorry, can I have the next slide, please? Am I frozen? Oh, okay, that's fine. So this is a brief outline of what I will cover, just to give a flavour of where it all started, what the memorable and landmark points have perhaps been along the way, and what we can see in the crystal ball. And then I'll hand over to Tom, Claire and Richard for all the important stuff. Next slide again, please. So medicines optimization is a bit more sophisticated than medicines management, in that it is about improving quality, outcomes and value for patients from their use of medicines, which is obviously vital. It looks at the value which medicines deliver, making sure they are clinically effective and cost effective, which is what we try to do. It is also about a higher level of engagement with patients and the public, as well as breaking down the barriers between professions, and it incorporates concordance and adherence, and we try to fit all of these into every medicines optimization project that we undertake within AWMSG. Next slide, please. So the All Wales Medicines Strategy Group is a committee that was established in 2002, which is 19 years ago now. It was a statutory advisory Welsh Assembly sponsored public body under the 1977 NHS Act to advise the Welsh Government and or the Welsh Assembly in those days on all matters related to prescribing. So in essence, it acted as a National Medicines Optimisation Committee across Wales, together with the HTA remit, of course. So the first meeting they had was in Wrexham in October 2002. And at this time, there was very little nice guidance around in 2002. So AWMSG developed its own. Now, of course, we aim to complement and support the work of NICE and avoid duplication where possible. So from the beginning, AWMSG worked to support implementation of as many as possible of the recommendations which were developed by the 2001 Task and Finish report on prescribing, commissioned by the Welsh Assembly, of which there were 96 recommendations. These included development advisory committees, use of patients' own medicines in hospital, and the formulary development as well. So many recommendations, as you can see, and it was a huge task in itself with all those recommendations. Now we have our own AWMSG medicine strategy, and the current one is from 2018 to 2023, a 5-year strategy to which all the medicines optimization initiatives we undertake should align, taking into account, of course, within any new therapies and the ever-challenging NHS resources that we currently have. So yeah, obviously we're looking at gene therapy and all the ATMPs as well within our strategy. So going on to look at the first national prescribing indicators, which were developed in 2003 and were initially chosen based on published indicators that have been selected to have face validity for measuring quality or cost minimization using existing prescribing analysis and cost data that was available then. So AWMSG chose generic prescribing as the cost minimization one, and then hypnotics and anxiolytics and antimicrobials as the quality and safety. So there were 3 big indicators at that time. Claire, of course, will talk about where we have gone since then and where we are going with these in more detail when she speaks. The guidance that was developed, these are very challenging treatment areas back in the day. For those of you where it is not etched in your memory, there were significant debates around the 4S study. So it was a real challenge getting the statin guidance recommended in 2004, as you can imagine. Next slide, please. Sorry, next slide. Thank you. I put this up because our old clinical director, Professor Routledge, has always been proud of this slide. Prof Routledge was obviously a previous chair of AWMSG for many years, so I couldn't leave it out. It shows the progress of one of our first NPIs, generic prescribing. So we started out the worst performing, as you can see, back in 2000 of all the home nations, and then in 2006 overtook them in percentage generic prescribing to reach 85% for quite a few years. In the more recent years, of course, it's tailed off due to increasing appropriate branded prescribing and other factors. But nevertheless, it remains as one of our landmark initiatives of which AWMSG is proud. So I had to show that. So next slide, please. So I just want to talk about the resources that are vital to for AWTTC and AWMSG to develop any meds-op guidance. ORPAG, the All Wales Prescribing Advisory, is vital for the development of appropriate guidance. It's multidisciplinary, specialist, and the coalface experience that we have from this group, together with lay inputs and, of course, broad geographical representation, which is very important. Localities obviously have their own specific needs for meds-op. Important to have liaison with all the ones and their nuances. So it is important Welsh Health Boards, Medicines and Therapeutics committees to ensure relevance of the guidance. I can't see anything or hear anything. What about the next slide, please? Okay. Okay, well, I'll carry on then. I'm not sure if anybody can hear me. Can somebody message me if you can't?
I can hear you, Kath. I think it's just a bit of a delay.
So
on
data is obviously. But you can hear me, can you?
Yes.
Okay. Could I have the next slide then, please? Okay, so data is obviously very helpful for us to develop our medicines optimization, but it's very frustrating as some of the data is not available to us, is not currently linked to indications, and it's difficult to demonstrate outcomes with meds op activity. But we all live in hope of this all the time. So the last slide, which you can now see, which is future meds op activity. These are exciting times ahead. I feel a lot of it will be dependent, though, as I've said, on good supporting data. The value-based agenda is indeed one of our priorities at the moment, and we certainly intend to move forward with this to support both prescribing investment and disinvestment in search of better outcomes. Another priority is inequalities and helping to support reduction in such variation in prescribing across patterns across Wales. And needless to say, again, sustainability is also a priority within the Awmsg strategy, with one of our focused agenda items being taken through ORPAG and Awmsg at the moment, reducing the inhaler carbon footprint. As such, you're probably aware from seeing the consultation that we're currently taking 2 updated respiratory guidelines through our process to support the green agenda, and these are due to go to Awmsg next month for consideration. So there are many other areas where we can support sustainability, such as medicines waste, and we will work collaboratively with all the relevant stakeholders to ensure progress on this. I will now hand over to Tom, who will tell you about our medicines optimization framework process and work programme. Many thanks for listening.
Thank you, Kath. Hi, everybody. I'm Tom Curran, and I work as a scientist as part of the Welsh Analytical Prescribing Support Unit at AWTGC. I'm going to be talking about what we're doing now, how we're doing it, and then also how you can help and get involved. So next slide, please. Thank you very much. So as an overview of what I'm going to cover, so we're going to talk about what kind of work and projects medicines optimization encompasses for us, give you a look at some examples of what we've published recently. As part of that, we've recently published what we call the medicines optimization framework. So I plan to cover what that covers, how it helps kind of make our processes a bit clearer openly, and then also give some detail on how you as representatives of the industry can get involved in our work, and then give a view as to what projects we currently are working on and what consultations maybe are on the horizon that you might want to get involved with. So next slide, please. So if we look at the different categories of the work that we produce, if you look on screen now, this is kind of how we organize our work at the moment online on our website. One sec. So prescribing guidance is probably the biggest category of the work we produce. This aims to provide practical guidance for healthcare professionals in achieving the best outcomes from medicines for their patients. These can cover a broad range of therapeutic areas which are applicable to practice across NHS Wales. Resources may be as broad as providing practical guidance and resources to support structured medication reviews with patients, or maybe providing practical guidance focusing on a single and specific therapeutic area or condition, and make recommendations on the best prescribing options based on a patient's specific individual characteristics. When we develop these guidelines, wherever possible and appropriate, they may also be supported by the development of patient information leaflets. So these are produced so that healthcare professionals can share these with their patients and explain the treatment decisions being made and hopefully support the principles of shared decision making. AWCC and AWMSG have also considered medication charts and templates for medication records in the past that may have been used in a single health board, and we consider them for adaptation and implementation across all Wales, such as the inpatient medication administration record that is currently available on the AWMSG website. Next, if we move on to prescribing analysis, utilising those national prescribing data accessible to AWTCC at the moment, we were able to produce analytical reports on different areas of prescribing and how prescribing is maybe changing and varying over time, but also between different regional areas. The most regular work we do in this area is prescribing analysis and producing quarterly reports on the performance of health boards against the National Prescribing Indicators, or NPIs, that are endorsed by AWMSG. And my colleagues Claire and Richard will be speaking about these in a bit more detail in a little bit. Next, Therapeutic Priorities and Kep, so this stands for the Clinical Effectiveness and Prescribing Programme. We produce some resources to go hand in hand with the NPIs and also AWMSG's own therapeutic priorities. These highlight opportunities within what is known as the Kep framework, where prescribing initiatives can be undertaken to support these same priorities. And lastly, we have audit materials. AWTC and AWMSG work to develop and endorse materials that can support effective audits of a range of prescribing areas. For example, we've produced audit materials for auditing the prescribing of antipsychotics, but also performing regular patient reviews of patients receiving antipsychotics. Next slide, please. So if we look more specifically at some examples of work we've done in the last 12 months or so, you get a sense of the broad range of resources we produce. And what you see on screen here doesn't include what we produce and publish to the NPIs. So in August last year, we published the Asthma Management and Prescribing Guidance. This was developed by the Respiratory Health Implementation Group in Wales and was then taken through our process of consultation and endorsement. This resource provides very practical guidance on the inhaler options suitable for patients depending on the severity of their asthma. This, as well as similar COPD guidance, which was published in the year prior to that, has recently been updated and consulted on with a view to publication before the end of the year. This update, as Kath has mentioned, very much focuses on incorporating considerations around carbon footprint when selecting an inhaler. In contrast to that document that focuses on a singular area of prescribing, at the end of 2020, we also published the Welsh National Standards for Medication Review, which suggests a structured approach to medication review that can act as a benchmark for quality, all with the aim of optimizing patient safety and prescribing practice. Subsequent to its publication, we're also supporting and working with some GP practices to pilot the implementation of these standards and identify any possible barriers to its implementation. As a final example of something we've produced in the last year, I'd like to draw your attention to the best practice reminder document that's in the center of the image. This is an example of a very short, snappy document that was produced to address an identified safety issue with the prescribing of nitrofurantoin in patients with pyelonephritis. So where it is known that nitrofurantoin is ineffective. So the document sets out to inform prescribers that this prescribing should be avoided, sets out the rationale behind that, and then sets out what could be prescribed in its place. If you have the next slide, please. So also within the last 12 months, we have produced something that we're referring to as the Medicines Optimization Framework. This was published in April of this year, in response to some, there had been identified that maybe our processes and what we work on isn't necessarily open and transparent, and how we produce things, the process isn't necessarily well known and publicly made available. So we produced this document, and it sets out which has already been covered. What do we mean in AWTC and AWMSG by the medicines optimization? It sets out details about the types of resources we produce. And then also it sets out how new projects are proposed, how those proposals are considered. I'll be going into a little bit more detail on this in a second. And then once a project proposal is accepted, how we undergo the development process, what stages are involved, and then provides detail on how consultation is performed, and also subsequent to endorsement and publication, how we review publications over time and keep them up to date. And then lastly, touches on some future work that we're looking at in terms of how we can improve our processes, and just some initiatives around medicines optimization that are currently being looked at. If you want to find this document, please do look at this document. It gives hopefully a clear overview of how we do what we do. So please go to the AWMSG website. If you search for the keyword framework, it should come up as the first result. And feel free to comment both on whether the document is understandable. If you have any queries, get in touch, but also if you have any ideas for how we may be able to improve our processes, also we're very welcome that feedback. Next slide, please. So as a quick overview of the process that a project would go through, we have the project proposal. So we do say that anyone can propose a project, whether it be healthcare professionals, professional bodies in the healthcare or healthcare professionals, but also members of the public can propose projects, but also you as representatives of the industry, we welcome your project proposals as well. And again, I'll go into a little bit more detail on how you can do that in a second. Once a project proposal has been accepted, so this goes through senior management team in AWTC, followed by the AWMSG's own steering committee. The project, when taken forward, then goes through phases of development. So this is working with AWTC to get that document ready for its first consideration at an All Wales Prescribing Advisory Group meeting. So these are quarterly meetings. The group representative of professions throughout Wales, and they'll consider the guidance, flag up any issues, and ultimately get the document ready to undergo open consultation, where the document is made available on our website. Anyone can submit consultation comments. We compile those comments. They're considered by the project lead, so those who propose a project, AWTC, and ultimately by ORPAG, again at a following quarterly meeting. And ultimately coming out of that meeting, we want to have agreed that we've responded to consultation comments appropriately, and that we are happy with the document to proceed to AWMSG endorsement. So once the AWMSG steering committee accepts that the paper is appropriate for consideration at an AWMSG meeting, it then gets considered by the AWMSG committee, the same committee that reviews the appraisals and is involved in the appraisal process. That same committee also considers all our medicines optimization resources, and ultimately aim for them endorsing it and going forward with publication on our website. Next slide, please. So the first stage in that process is the proposing of any new project ideas. As I've already mentioned, anyone can propose projects, including yourselves as representatives of the pharmaceutical industry. This simply is filling in what we refer to as the new project proposal form. There's a link to this from the Medicines Optimization Framework document, but also on the web page you can see there, which hosts the Medicines Optimization Framework document. Please do provide as much detail as you can in these project proposal forms that help us make the best informed decision about whether it's something we would take forward. We did want to take this opportunity to say that we don't receive that many project proposals from industry, and the ones we have received to date tend to be focused on maybe understandably promoting a specific product in your portfolio that might be recommended above others in the same therapeutic area based on cost alone. These are not the types of projects we would tend to take forward, as we consider considerations of products based on cost to be something that should be done on an individual health board formulary basis. But other than that, please do submit project proposals. Any ideas you have, they will all be considered on a case-by-case basis, and we will respond to everyone we receive. So next slide, please. In addition to that, we also want you to be involved in our consultations, but also, and you can see what's coming up on our work program. You can see on the web page image there is a consultations area, but there's also a work in progress area on the website that provides an overview of every project we're currently developing and some rough dates for when we expect to hit various milestones, so consultation and ultimately publication. Next slide, please. So if we look at some examples, if you go to that web page now, you'll see a good number of projects there at the bottom of the list, which we are currently working on and are approaching probably consultation in the next month or so. 4 of those projects are all kind of interlinked with each other. It's all in the area of antimicrobials. We have, and the primary care antimicrobial guidelines and the national audit are updates to existing guidance, mostly being updated to align with more recent NICE guidance and make it applicable to Wales. So these are quite big documents. So we have the antimicrobial guidelines themselves, the supporting national audit materials to go alongside that and help GP practices monitor whether they are meeting those new guidelines and prescribing in line with them. And then linked to that are some supplementary, more detailed guidance on the management of C. diff infection in Wales and also recurrent symptomatic urinary tract infections. And then separately to that, the last one on that list there is the All Wales advice on oral anticoagulation for non-valvular atrial fibrillation. This is a document that was published early last year in 2020. And since then, NICE have updated their guidance, so we are publishing an update to align with that. So this will be to reposition DOACs above warfarin in terms of when they should be prescribed, in terms of being first choice, and also changing the recommendation on a bleeding risk tool to be used, so moving away from HASBLED. So as I say, these are all consultations that should be coming up in the next weeks and months. These will be easily accessible on our website. We do really welcome any feedback you might have. The amount of engagement we've been having on these consultations has been steadily increasing, I would say, from industry. And we do try and respond to all your comments, and often this leads to important changes being made to the documents. So we really appreciate your feedback. Next slide, please. So as a summary of what I've gone through and what we kind of want you to go away with is, please explore our resources, share your feedback on anything that's already published on the website. More specifically, please look at the Medicines Optimization Framework. We hope it provides a clear overview of our process, and then give any feedback on how you think maybe our processes could change in future. Also, please do submit any project ideas you have, and also please get involved in our consultations. We know you do this already, but want to continue to encourage that because all your feedback is really valued. I just want to say thank you. I will be handing over to Claire and Richard, but I don't know if we have any questions in the meantime. No questions yet. Okay, cool. So Claire, over to you. Thank you.
Okay, thank you, Tom. So my name is Claire Thomas and I'm a pharmacist with the Welsh Analytical Prescribing Support Unit. So myself and Richard Bolderow are going to be talking to you about the national prescribing indicators. So as Kath has already mentioned, MPIs were first introduced in 2003 and originally were fairly simple measures, often looking at cost, but also quality as well. So since then, the MPIs have evolved to encompass a variety of measures and utilise a variety of data sources. Every year, the MPIs are reviewed and refreshed to ensure that they remain of value and are fit for purpose, and to consider any new therapeutic areas or priority areas that are important for NHS Wales. So the exception to this being 2020, for obvious reasons, COVID. Due to workforce pressures across the service, we weren't able to start the sort of 9-month review and update process last year. So as a result, AWMSG agreed to roll the 2020-21 indicators into this current year of 2021-2022. Next slide, please. So although we weren't able to undertake the usual update and refresh, the sort of pause in that did give us time to consider whether it would be useful and whether there'd be an appetite for altering the start of when we undertake the process to enable the indicators to be endorsed earlier than usual, thereby giving health boards more time to kind of plan their work and plan their prescribing incentive schemes around the indicators. So it was felt by ALLPAG that this would definitely be of benefit. And so we started preparing the update and refresh for the 2022-23 indicators in March of this year. So we sent out an MPI questionnaire to all of our stakeholders, chief pharmacists, medicines and therapeutics committees, GP practices, and everybody that's usually involved, to gather their feedback and thoughts on the current MPIs and to share any ideas for priority areas going forwards. The feedback then was discussed by the NPI subgroup, which is a subgroup of ALLPAG, and considered the feedback from the questionnaire and also brought their own thoughts to the meeting as well. So then in March and June, the NPI subgroup feedback was discussed and proposals developed, data was looked at, and again in June we came up with a final sort of list for consultation. So over the summer, the draft document was worked on within the organisation, and it was circulated for consultation in August and during the beginning of September as well. So the consultation comments were reviewed. We had the ALLPAG meeting yesterday where a number of the comments were discussed, agreements made as to changes to be made to the MPIs and the document. Those changes will be made, and then the document will go to AWMSG at the end of the year for endorsement. After that, obviously, then the website will be updated with the current document, and it will be circulated as well. So that will be available if you want sight of that towards the end of the year. So by endorsing them earlier, it does, as I say, give health boards extra time to kind of plan their work around the MPIs and tie in with prescribing incentive schemes. Next slide, please. So when developing prescribing indicators, what do we look at? Well, obviously it's important that the indicator is evidence-based. We're not just going to pluck something out of thin air. We need to have a good reason as to why we're going to introduce an indicator and why we're going to monitor it. The indicator needs to be clear and easily understood by prescribers and health boards so that they know, what are we measuring, why are we measuring it, and what is the actual unit of measure that we are going to use. The indicators should be standardised where possible to allow fair comparison then between GP practices. Obviously they have different types of populations, different list sizes, health boards as well, different populations. So we try and standardise them as much as we can to allow for fair comparison across the board. Indicators ideally should have an aim or target as well, so that practices know that they're moving in the right direction. If they're moving towards a threshold or they're meeting the target, is it increasing the use of something, decreasing the use of something? So they need to know which direction of travel they're sort of aiming for. And ideally they should address quality, safety or efficiency. If all three, then that's even better. But those are the sort of main areas that we are focusing on, and the quality areas, safety and efficiency. So that's usually cost efficiencies. And then finally, the indicator should be validated by a group of experts. So in the case of the National Prescribing Indicators, the All Wales Medicine Strategy Group are the group of experts that validate the indicators for us. Next slide, please. So with regards to reporting on the National Prescribing Indicators, we publish quarterly reports with the latest data available. These are available on the AWMSG website, and they are circulated via email as well. So these are just really top line reports, just looking at health board information, looking at the latest quarterly data in comparison usually to the same quarter of the previous year, just to give a snapshot of where things are going. And the reports contain trend graphs as well, and just highlight maybe the health boards that have performed better or slightly worse in each particular area. But for more in-depth analysis and interrogation, the Wales Therapeutics and Toxicology Centre a few years ago developed Spira, which is the server for prescribing information reporting and analysis. So that enables health boards, GP practices themselves, anybody with an NHS connection to drill down into each of the indicators, drill down to cluster level, to health board level, look at various trends, look at how many practices in a health board are working, moving towards a target, how many practices are moving away from a target. So it's an interactive dashboard with loads of information, but as I say, it is only available to people with an NHS network connection, so it's not publicly available, but it's really useful to health boards, and since the introduction, it's really gone down well. Next slide, please. So although, as I mentioned, we were unable to update and refresh the MPIs for this year, we have updated the targets and thresholds associated with the indicators. So these are the indicators here for the current year. So we've got 3 priority areas of analgesics, anticoagulants in atrial fibrillation, and antimicrobial stewardship, and they're supported by safety and efficiency domains. Next slide, please. So the first priority area is analgesics in primary care, and all 3 of these indicators have the aim of encouraging appropriate use and review to minimise the potential for dependence, diversion, misuse and ADRs associated with these medicines. So since the introduction of the tramadol indicator quite a few years ago now, and associated sort of support materials endorsed by AWMSG, there's been a significant reduction in prescribing, which is obviously fantastic and the whole point of the indicators. The gabapentin and pregabalin indicator only came in a couple of years ago, and as we know, it takes a long time to sort of change prescribing habits. So use of gabapentin and pregabalin has been going up steadily for the past few years. However, I think there are glimmers of hope now, and that big ship is turning very slowly, and we are starting to see a slight reduction. So hopefully the next few quarters worth of data will continue to show a decrease in that. Next slide, please. So the second priority area is focused on anticoagulants in atrial fibrillation, and we've got 3 indicators within this section. So these indicators utilise a different data source to the usual dispensing data that we historically used and still do continue to use. So we've worked with Digital Healthcare Wales, they used to be called NWIS, I can't remember what DHCW exactly stands for now, to develop some searches. So the data is extracted directly from GP practices to identify patients there within each of those 3 indicators. So the practices themselves have lists of all the patients that fall within these indicators. However, as an organisation, we only have access to the data at cluster and health board level, and only report on these indicators at cluster and, as I say, health board level. But individual practices do have that data down to patient level, and the aim is really that obviously GP practices review and ensure they're recoding appropriately those patients that fall within those indicators there. Some of you may have heard of the Stop a Stroke project as well that's going on across NHS Wales, and so these 3 indicators tie in with that sort of work. Next slide, please. And then the final priority area is antimicrobial stewardship, and both of these indicators focus on appropriate antimicrobial use, as we're all well aware of antimicrobial resistance due, in part to excessive and inappropriate antimicrobial use. As Thomas previously mentioned, the primary care antimicrobial guidelines are currently being updated, and they'll be out for consultation shortly. So you may notice there total antibacterial items per 1,000 star PUs. Star PUs are a type of prescribing units that we use to try and, again, standardise the prescribing data to allow fair comparison. So star PUs are specific therapeutic area age-related prescribing units to account for often increased use of antimicrobials in female patients and children. So to standardise that really and allow fair comparison. Next slide, please. So within the safety domain then we have 4 4 different safety indicators, the first of which being the prescribing safety indicators. Again, these utilise data directly from the GP practice, and again, we only have access to this data at cluster and health board level rather than individual practice level. So there's quite a few indicators within this set, and we categorise them either as relating to AKI, bleeds, cognition, related to females. So, for example, sodium valproate use in females, or a sort of other category which captures, for example, aspirin use in under 16s and patients with asthma who are prescribed a beta blocker. So the aim of these is that there's a lot of overlap with the pincer indicators, if any of you have heard of those. They're being used in England. And obviously the aim of these is to identify patients who may be at high risk of an adverse drug reaction or medicine-related harm. So GP practices will have a list of these patients, and it's about ensuring that these patients are highlighted and reviewed. You know, perhaps it is appropriate for that treatment to continue, but often it might not be. And so if the GP reviews them and makes a change, we're hopefully presenting some kind of medication safety issue there. Next slide, please. So proton pump inhibitors are also included within the safety domain due to the increasing evidence regarding adverse effects as a result of a long-term use, so increased C. difficile infection and fractures. Use of PPIs were declining, however, the issue around ranitidine, which I think has been around for about 2 years now, has unfortunately resulted in PPI use starting to creep back up again, but we've retained that within the safety indicators for this current year. Next slide, please. Hypnotics and anxiolytics, as Kath mentioned, was probably one of the first indicators introduced, and we're still monitoring it to this day. Since introduction, though, there has been a steady decline in hypnotic and anxiolytic use. However, overall use in Wales is still high when compared to England, so we are continuing to include that within the safety indicators. Recently, AWMSG have endorsed the updated hypnotic and anxiolytic resource materials to help obviously practices in reviewing patients and developing perhaps a practice policy around the use of hypnotics and anxiolytics. So again, concerns over misuse and abuse have resulted in this indicator being introduced and allocated to the safety domain. Next slide, please. So finally, the last indicator within the safety domain is yellow card reporting. I think this was introduced about 6 or 7 years ago, and since the introduction of this, yellow cards in Wales reporting did increase when the indicator was introduced, which is really great news. So we look at yellow card reporting broken down by GP practices, health boards, secondary care, community pharmacists, member of the public reports as well, and look at the reports submitted in each of those different categories across each of the health boards. There has been a decline over the last year, obviously due to, we all know why, but hopefully things will start picking up again with regards to yellow card reporting. And we have specific targets for GP practices, secondary care as well, a member of the public report. So it's about educating the public that they can also report any adverse effects via the yellow card system. So that's the end of my section. I'll hand over to Richard now, who's going to talk about the efficiency indicators.
Thanks, Claire. So I'm Richard, and I'm also a pharmacist working within the Welsh Analytical Prescribing Support Unit. I'm going to mainly cover the efficiencies measures within the National Prescribing Indicators. So in 2021 to 2022, we currently have 3 as shown on the slide. However, following consultation, we will be discontinuing the long-acting insulin measure from 2022 2023 onwards, and therefore for the majority of this remainder of the presentation we'll just focus on the other 2 measures, the best value biological medicines and the low value for prescribing. Could I have the next slide, please? So this is data for the current basket within the best value biological medicine MPI. As you can see, hopefully on the right hand side in the top corner there is the listed biological medicines which are within that basket. This MPI has been running since 2016-2017. And as you can imagine, the basket has changed during the course of the indicator so far, with probably only Infliximab being one that was really introduced from the start and continues. One of the main prerequisites, as you can imagine, from an efficiency indicator is there has to be a benefit in using the biosimilar medicine as opposed to the reference product to actually gain efficiencies for NHS Wales. And that is something that we check on regularly to make sure that they're still valid and therefore to still include the best value biological medicine specifically within the basket. As you can also see on the left-hand side, the y-axis has a percentage as a measure. This is a percentage of the biosimilar products over the total use of the best value or the biological medicine. This is seemingly possibly quite a basic measure, and it is certainly compared to some that are used in England and Scotland. However, we do have to undertake a relatively complex process in actually getting this data together. The secondary care data system within Wales doesn't allow an easy retrieval, and colleagues within the data analysis team actually undertake multiple calculations to actually get a percentage figure. We also, where relevant, include primary care data within these figures, and that too obviously is more complexity to actually get these standard percentage figures. Next slide, please. So that's currently where we're at, but there has been a bit of a journey, should we say, to actually get to this point. And so when the indicator was first investigated around 2016, we were having discussions within ORPAG, and obviously we have ABBPI membership there, and Rick was able to inform us that there was currently this document being worked on of what is a biosimilar medicine. And this was really something that was absolutely crucial in supporting the indicator, because it gave background information that was available at the time to inform clinicians and prescribers and pharmacy teams and anybody really who's had an interest in the indicator, some of the background information. At the time, there wasn't that much information that was really freely available for people to use. At the beginning of this year, there was a paper published in the Biodrugs Journal, which was written as a consequence of a student undertaking a PhD thesis. And this was undertaken at the University of Leuven in Belgium. And it investigated the uptake of biosimilars, particularly for Infliximab and Etanercept within the UK nations. Within the research team, there were other academics who had extensive experience in researching biosimilar uptake and had done similar studies for some of the countries within Europe, particularly Sweden was one that they did a considerable amount of work for. And what this paper reported is that the effective uptake of biosimilars, particularly Infliximab and Etanercept, was influenced by a number of factors. These were a price difference between the biosimilar and the originator reference product, and as I've just mentioned, that is something that we've always incorporated within this indicator. That there should be leadership of biosimilars across Wales and within the health boards, and obviously having an indicator, national indicator, that does provide a form of leadership. And also we developed, as Claire mentioned, within Spira, a biosimilar dashboard, which specifically allowed anybody within NHS Wales with a login for NHS Wales to actually access data to show how their particular health board was comparing to others. And what I also found is that an important driver was to have key opinion leaders from those areas that maybe have taken on biosimilars quicker than other areas. And at the beginning of 2019, we held a biosimilar best practice day. And this brought together not only clinicians, pharmacists, but procurement teams and academics to have this, if you like, a round table discussion of the issues involved with biosimilar uptake. And this enabled some of the health boards that had taken a more prominent lead in adapting the biosimilars to actually share their experiences from that, and hopefully then to have allowed and to informed people from across Wales. The next slide, please. Next slide, please. Thank you. So this, as you can see, focuses on three particular biological medicines: adalimumab, etanercept, and infliximab. And I think it's fair to say that within the basket of medicines, these are probably the three most prominent ones in terms of providing efficiency benefits. Hopefully you can also see that the steepness of the curves changes as we have introduced the different medicines within the basket. And this is reflective really of some of the challenges that have been faced as we've developed the indicators. So with infliximab, as I said, this has pretty much been in there from the start. And a lot of the issues around the uptake of biosimilar infliximab is related really to clinician concerns around safety of biosimilar medicines, and then also around the practicalities of switching patients who had obviously been established on the reference product and effectively treated. Infliximab was obviously, as you know, is mainly administered within the secondary care setting due to the fact that it's an infusion. And so when we came to etanercept, and etanercept being biosimilars being adopted, there's a slightly different focus then, because we may have allayed any concerns around some of the safety issues, but then etanercept, because of its being subcut dose, was mainly given via home care, and so there was other issues then that had to be explored about how to put a process in place for switching within the home care setting. Again, these had been addressed then through the use of biosimilar etanercept. So the time we came to biosimilar adalimumab, which was probably our last major biological medicine to have a biosimilar version available, a lot of that learning had obviously been gained, and that allowed that much quicker uptake of the biosimilar version. What I'd also like to say with these particular medicines is that we've done some analysis over a particular period of time for each of these, and we've been able to show that yes, there have been efficiency gains in terms of a decreased spend overall on each of the individual biological medicines. But we've also been able to show at the same time there's actually been an increase in the number of items that have been supplied to patients within NHS Wales. And I think this is something that we are really keen to stress, that it may be an efficiency-based indicator, but actually it's allowed more patients to actually access these innovative medicines. And I'm sure that everybody's aware for conditions such as, for example, rheumatoid arthritis, the earlier the patients can actually access these medicines, we can hopefully prevent some of the more destructive elements of that disease happening, and allowing patients to be hopefully symptom-free for a much longer period, whilst obviously stabilized on these medicines. Next slide, please. So very briefly, just to mention also that going forward, so for 2022-2023, the basket, we are expecting to incorporate bevacizumab biosimilars and also ranibizumab. Now, obviously, due to the nature of the market, obviously, we're not exactly sure when these will hit, but hopefully they will be able to incorporate right from Q1 2022 data. And hopefully then we can also show a similar pattern to what we've seen with adalimumab in the uptake of these biosimilar versions of biological medicines. Next slide, please. So that concludes around the best value biological medicines. The other efficiency indicator that we have is the low value for prescribing medicines. So these medicines, this work was very much something that was developed as a medicines optimization project. And that's continuing. So, but within the National Prescribing Indicator, it is paper 1 and paper 2, which make up the basket of medicines within that. The first paper was published in October 2017, and this included 5 items. Now, although this is an efficiency focus, we've also used the initiative to draw attention to some safety concerns with medicines. So one of the items that was included within the basket here was coproximol. I'm sure many of you know that coproximol is a medicine that has been licensed in the UK for many years, but we found that from the data that we had, there was continued use pretty much across all health boards. So in conjunction with the Chief Medical Officer and Chief Pharmaceutical Officer, who issued a joint letter to health boards requesting that all patients are reviewed who are currently still taking coproximol, we were able to incorporate that within this initiative. And since then, we've seen that there has been a further decrease in the use of coproximol, and so that currently 4 health boards have no patients at all receiving coproximol. And although there is some residual use, we'd like to think that is in a very small number of patients who actually have no alternative treatment available. And I think that's something to also stress with this initiative, is that this is not necessarily, even particularly with safety concerns, it's not absolute that there's no prescribing whatsoever. The purpose of the initiative was to decrease routine prescribing. So some of the other items that are included in paper 1 was oral liothyronine. Again, I'm sure many of you are aware of the recent publicity around the significant increase in the costs of generic liothyronine. And that's one of the main reasons why it was incorporated within this initiative, due to the significant increased costs, but lack of any evidence to suggest that it was any preferential to oral levothyroxine. Again, we know that there are a small subgroup of patients who do benefit from oral liothyronine, and that is something that we've incorporated within the guidance, but to emphasize that it shouldn't be the routine prescribing. Another item that was included was Lidocaine Plasters. So Lidocaine Plasters have a narrow license indication of post-herpetic neuralgia. But prior to the introduction of this initiative, we were seeing quite significant increases in the use of lidocaine plasters year on year. We have undertaken a year or two ago a collaborative project with the Swansea Centre for Health Economics, the Swansea University, and the Centre for Health Economics and Medicines and Valuation at Bangor University. And part of that work was able to show that the usage of lidocaine plasters was greater than the population estimates for patients who would have post-herpetic neuralgia and requiring these plasters to be continued. And that was very informative, and obviously allowed us to have some further learns within this project. The data currently shows that we haven't had a significant decrease in the use of lidocaine plasters, but we have flattened off that growth curve. And that would again align to what you'd expect really with the population to which the plasters are indicated. Paper 2 was introduced in December 2018, and this had 4 items within the basket for that. For the examples would be the omega-3 fatty acids and some of the combination painkillers such as paracetamol and tramadol. So they're what make up the National Prescribing Indicator basket. And then in February of last year, we published the paper 3. Now, this unfortunately was very close to when COVID hit, and so there was a delay really in the implementation, active monitoring of this paper, and it commenced in April this year. This paper had 11 items and also had some of the focus on safety again. So we had things like chlorohydrate, aminocycline for acne. There were some items which were around the efficacy of them, so things like probiotics and rubifacients, and then some which had a purely more efficiency focus, where there may be more cost-effective options available, such as things like alamemazine. Next slide, please. And this very quickly just shows the data from the MPIs, this papers 1 and 2, the spend per 1,000 patients, and that's been over the course of the 3-year duration. And you can see that there has been decreases across the health boards in Wales, but equally there continues to be some prescribing. And as again, just to emphasise, that is not necessarily what we're not looking for in terms of just decreasing that routine prescribing. And next slide, please. And just to mention, as almost like a flip side to the low value for prescribing, is that this isn't within the national prescribing indicators, and it is very much a medicine optimization project or initiative that's very much in its formative stages. But we're looking at trying to put together a basket as such of medicines where they're supported as a prioritisation. So across Wales, there's been a number of quality standards statements published. One example is that for heart conditions, and this encourages the use of certain medicines, one of which being sacubitril/valsartan combination product. Also, within England, as many of you are aware, that there is an accelerated access collaborative, and this is looking to focus on certain medicines to increase their usage, really, due to their innovative nature. And one that we've started to investigate is the use of biological medicines in eosinophilic asthma. And so this is something that we're, as I said, very early stages. We'd welcome any comments really on other things that could be included, because we are doing that very much the scoping aspect, and any comments and thoughts and contributions really would be grateful for us to start that investigation to see the feasibility of those. That concludes my section. So I think that's it for us. So I'll hand back to Stephen. Thank you.
So everybody, thanks team. I'm conscious we're out of time. Any last questions, feel free to put your hands up in the chat. But thank you. Useful to have a conversation about value-based prescribing, reduction in prescribing variation. Quick question while I'm here. How would you answer anybody who wonders how you translate reduction in prescribing variation to an improvement and a reduction of an unwarranted variation in patient outcomes, which ultimately we're all trying to achieve across NHS Wales? Any last thoughts on that?
Should I? Well, I can certainly, in terms of that's kind of where we're hoping the high value prescribing strategy may help, because we're trying to focus on medicines that have single indications. And so by using data for those medicines, we may be able to make links to some of the outcome data that's also available. So for example, with asthma, it could be admissions due to asthma. We're also, I think, all of us tentatively confident that we're going to have more sophisticated data available within the next couple of years. There's an announcement of the Welsh Government recently about prescribing data, and that also would help to then link into any outcome data that we're also able to pull together.
Yeah, no, thank you. That's helpful. I'm not seeing any other questions in the chat just now. This is your last minute. If, of course, you do have more questions after the meeting, feel free to drop the team at AWTTC and email awttc@wales.nhs.uk, or get in touch in any of the other usual ways. Other than that, it's time to finish, I think, everyone. Thanks once again to the WAPSU team, to Kath, Tom, Claire, Richard. We really appreciate your time, and look forward to next time. Next time is on, oh, I had it. Next time is on, I haven't got it here. Sorry. You got the date of the next meeting, Steph? Here we are. Next is One Wales process on the 18th of November. So come and join for that conversation, an hour, focused hour in the morning, One Wales process. And perfect. Meantime, I wish you all a fabulous day. Thanks everybody for your time and engagement. Oh, hang on. We have a question. Okay, they're just thanks in the chat. Thanks everybody. Good to talk. Enjoy your day. All the best. Bye now.
Thank you. Bye.